the largest joint in the body. Whether standing, squatting, walking, or running, the knees bear the full weight of the body. When one suffers from knee pains, his quality of life suffers too. Unlike mainstream protocols, the Knee Health Promotion Option, KHPO protocol, is built on new findings and employs novel arthroscopic procedures to reduce harmful use of the knee and to treat knee osteoarthritis, or knee OA, without replacing the knee. This is Gao Ronghong, 19. His knee pain used to make walking difficult for him. Wang Hongying, 65, had to stay close to home because of her knee pain. Knee pain degraded the quality of life for the young man and the retired teacher alike. The knee is the key to lower body mobility. It needs an adequate range of motion and stability in order to carry out complex movements and hold up the weight of the body and gravity. During everyday activity such as walking, jogging, getting up or down stairs, sitting, or squatting to tie your shoes, the knee bears 1 to 9 times the body weight. An accident may cause damage to knee cartilage, which over time will impair the person's mobility. Gao Ronghong was once a cadet at the Army Academy. He had always wanted to be a soldier, but his knee pain got in the way of that pursuit.
The doctor said I had inflammation. My knee felt hot. When it got really bad, I had to use my good leg more to walk and support my weight. Almost every step that I took hurt badly. Even walking on a level surface hurt. It hurt even more walking on an incline or walking up the stairs.
Gao could not understand why walking became so difficult for a young man like him. He couldn't keep up with other cadets in physical activities.
Physical activities were part of the training at the academy. My knee pains often prevented me from participating in those activities. It made me feel that I was a drag on other cadets. I felt quite inadequate. I sought help from many doctors, but I was never sure about what was wrong with me. The doctors all said more or less the same thing. Something like arthritis or patellar tendonitis. But it seemed to me that they weren't sure.
Wang Hongying is a retired teacher. Her knees began to bother her when she was in her 40s.
One day when I was 46, I couldn't stand up from the squatting position. I went to a doctor, and the doctor suggested that I undergo arthroscopy. So I did on both knees. But the pain returned when I was 59. The doctor asked me to wait till I was 65 to receive knee replacements. My goodness, how was I going to live with pains like those? The pains felt as if they would tear me apart. They were excruciating. When I was 60, A friend told me about new therapy called PRP, or platelet-rich plasma. I was thrilled to have a moment of hope. I got 3 shots of PRP for $2,900 American dollars. The doctor said they would last 2 years, but I got only 9 months out of them. I knew nothing better to do, so I went to see orthopedic doctors at many large hospitals. Almost often recommended total knee replacements, at least partial knee replacements. I wanted none of those because I knew that they hurt.
Unwilling to receive artificial knees, Wang Hongying waited for new therapies, and she quietly endured her knee pains and many other afflictions of the disease.
One day I went out to take the rapid transit. I was crossing a street when my knee locked up. I froze in the middle of the road as the traffic lights changed to red. I tied up the traffic, but I just couldn't move. It hurt when my right foot touched the ground. I wasn't even standing on that foot. A mere touch triggered pain so great that I dared not move. I didn't know what to do. Luckily, 2 college students lifted me to the side of the road. Once bitten, twice shy. After that, I became scared of going out.
Wang Hongying sought treatment from many hospitals for her aching knees. She also searched the internet for information on treatments for knee pain. Her search led her to Dr. Liu Shaorui of Dalian Tsuji Hospital. She had typical symptoms of knee osteoarthritis. There are 4 types of symptoms. The first is pain, of course. Second, it's stiffness in the knee. Third, the knee might get stuck without warning. And fourth, swelling that makes her very uncomfortable. Pain is the #1 reason for people to see the doctor. You become middle and then old-aged after your 40th birthday. Statistics show that 1 in 2 people over 40 suffers knee pain. But their age often lead their doctors to diagnose knee osteoarthritis, or knee OA. Their X-rays often show some signs of wear and tear. That and other typical symptoms, like pain, stiffness, stuckness, and swelling, lead mainstream doctors to diagnose knee OA. Dr. Liu Shaorui works at Dalian Tsuji Hospital. After his residency in orthopedics in 1990, he, like other orthopedic surgeons, believed that the only treatment for knee OA was knee replacement. However, as he gained clinical experience, he began to question the mainstream protocol for the treatment of knee OA. He set out to find the cause of knee OA. In the old days, I treated patients of knee OA in much the same way other orthopedic surgeons did. We knew that knee replacement could help patients. But most patients weren't serious enough for knee replacement, so we felt quite helpless. Gradually, I began to see complications of knee replacement surgeries. Circumstances like those made me wonder whether there might be a better treatment than knee replacement, and whether there was a disease process other than natural degeneration that could account for knee OA. Was there a risk factor hidden in the knee, waiting to be uncovered? In autumn 1995, an old woman with knee OA was waiting for knee replacement. Dr. Liu performed an arthroscopic lavage and debridement operation on her. During the operation, he saw a strange object which has led him down a lonely but thrilling path of discovery.
I saw an image that I had never seen before. Even though I'd already performed such arthroscopy 1,000 times before, I had never seen anything like what I saw in that woman. It was located in an inside corner of her knee, and no literature had reported it before. So I videotaped it, and instinctively I cut and removed it. The next day, the patient was very happy because all her knee pains were gone. She went home that day. More surprises awaited me. We usually follow up with patients for a year. Her follow-ups were excellent. She never asked me to replace her knees again. After that discovery, I looked for that lesion during my subsequent arthroscopic surgeries. That object has become the center of our research. That object is called Medial Plica.
One by one, Dr. Liu examined the files on the 2,000 arthroscopic operations that he had done over the years for patients from 13 to 79 years old. He discovered a high correlation between medial plica and knee OA. To understand medial plica, one must first understand the knee, which is the largest joint in the human body. The knee needs a sufficient range of motion and stability to withstand the force from gravity as a person carries out various complex movements. Flexion and extension are two primary motions in people's life. In a knee, you have cartilage that forms the ends of the femur and tibia, the meniscus that sits between the two bones, the ligaments that keep stability, and the articular capsule that wraps around them. Medial plica is a fold in the synovium. Almost everyone gets it at birth. It's a residual fold of the synovium that fetal development left behind.
Our main discovery centers on medial plica, which I call the hidden lesion. Let's look at its structure. In this 3D diagram, we can see it clearly. During the 3rd month of fetal development, the articular cavity is formed, somewhat imperfectly, leaving a crease on the capsule. A crease that is much like a wrinkle on a shirt. This crease is called the medial plica. The articular capsule is in light purple. The medial plica is in red. Under arthroscopy, this is a normal medial plica in a young man. You can see that it's very thin. It even looks a little transparent. Now this is the medial plica of an old man who received knee replacement. It's thick. The edge of the plica looks like a thick rope. Imagine how a medial plica like this one may rub on neighboring cartilage, causing an abrasion phenomenon.
To prove that medial plica could be an important etiological cause of knee OA, Dr. Liu planned and established a knee OA research lab in 2002. It initiated multidisciplinary research. Professor Liu Deqi of the Department of Mechanical Engineering at National Zhongzheng University is a member of that research team. His main research interests are kinetics and computer-aided engineering.
I'm responsible for two parts in the project. The first concerns the cause of knee OA. The plica is a soft tissue. When a plica becomes fibrotic, knee bending may cause abrasion on cartilage. There was no research anywhere in the world to tell us how hard plicae might become as a result of fibrosis. So we first developed an experiment to measure how hard a plica may become following fibrosis. When a plica hardens beyond a certain point, it causes damage to the adjoining cartilage. We then tried to find out how the angle of knee flexion affects the pressure that plica exerts on the cartilage when the two touch each other during knee motions. That was very difficult to measure directly because the entire motion that we tried to observe took place inside the knee, so it was virtually impossible to measure. Therefore, we used computer-aided engineering. We established a computer model to emulate the knee joint, the plica, and the cartilage, which is shaded green. Does this simulation reflect how a human knee moves? Dr. Liu and I conducted a very special experiment. He put probes into a patient's knee to mark the position of medial plica. Then we bent the knee to measure the distance the probes had moved. Then, in the model, we moved the plica the same distance. We verified that the model moved in the same way as a human knee. We validated the computer model.
It took us several years to build this model, which helped us find the magic angle, 50 degrees. Regardless of its physical size or Young's modulus, a medial plica will damage cartilage when the knee is bent more than 50 degrees. Young's modulus measures the hardness of an object. The smaller the modulus, the softer the object. Medial plicae of young people have low Young's moduli, which rise with age. So the older a person gets, the harder the medial plica becomes. When this number exceeds 10, 20 to 50% of cartilage will be damaged by the pressure. This is a unit in mechanics. For example, 11.2 megapascals means 11.2 kilograms of pressure on a square centimeter of surface. If the number is greater than 10, or 10 kilograms per square centimeter, then the pressure damages the cartilage.
In addition to biomechanics, we also work with Dr. Zheng Zhian of Dalian Tsuji Hospital Pathology Department to look into knee OA from a histopathological point of view.
On the screen is a complete synovial plica. This is the proximal end, and this is the distal end. In a healthy knee, this area should be the same as this area. This reddish-white area indicates abrasion,
The white shiny area indicates fibrosis. Under a microscope, this specimen shows varying degrees of abrasion. Abrasion classification presents a challenge. In medical literature, there were reports of abrasion on medial plica in patients of Neo-A, but there was no classification of plica abrasion. Therefore, I was unsure about what to do when Dr. Liu gave me this synovial plica. He and I needed to classify abrasions on synovial plicae from the least to the most severe. In 6 months, we had got a better idea and could tell them apart by sight. A healthy synovial membrane looks like spot A, a complete and smooth surface. This one shows damage. Traces of wear indicate the least severe damage, as in A. As abrasion continues, the top layer of it is totally worn out. We call this a second-grade damage, as in B. As the abrasion continues, so does the wear, and fibrosis begins to set in, as in C. Fibrosis eventually makes this protruded area fall off, leaving a flat area with severe fibrosis underneath, as in D. So we classify abrasions into 4 grades, A, B, C, and D. The research also teamed up with the Institute of Anatomy and Cellular Biology at National Yangming University to conduct biochemical analysis of medial plicae and Panas tissues around cartilage. We found that cartilage pinches or rubs on medial plica, causing inflammation, which occurs on the plica as well as the cartilage. New blood vessels form around this area, indicating inflammation. So we took out this section and conducted histological and molecular biological analyses. We dyed the tissues. The tissue on the left is healthy. The tissue on the right is diseased. We found the diseased medial plica had turned dark brown. The healthy tissue did not show this reaction. What does dark brown mean? It indicates a high concentration of matrix metalloproteinase. It's an enzyme that damages cartilage. When the tissue is inflamed, this enzyme is often present. It rots cartilage. After 10 years of research, Dr. Liu called the repeated abrasions between medial plica and medial femoral condyle medial abrasion phenomenon. This medial rubbing occurs at least 1 million times a year for an average person. Under normal usage, what will happen after such repeated abrasions? It causes 3 types of damage: physical, chemical, and third-party damage. First, abrasion leads to physical damage. We've proven that pressure causes medial plica to harden, which for people in middle age may cause direct physical damage if the knee is bent more than 50 degrees. If the bending exceeds 90 degrees, the pressure is even greater. Second, abrasion leads to chemical damage. Repeated inflammation of the medial plica and articular capsule causes the production of cytokines that stimulate catabolic enzymes that gradually erode cartilage. Either physical or chemical damage erodes cartilage and produces debris and particles that deposit in the medial compartment of the articular cavity. Particle sizes prevent the debris from entering the lateral compartment of the articular cavity. Therefore, debris stays and accumulates in the medial compartment where knee movements stir up debris and cause third-party damage. These three types of damage contribute to the damage to cartilage, which people commonly, but mistakenly, call degeneration. In fact, the real cause is abrasion, not degeneration.
Medial abrasion phenomenon can account for most symptoms of knee OA. The symptoms are collectively called medial abrasion syndrome. Wu Zhaoguang is 80 years old. His plan to enjoy retirement 15 years ago was derailed. His knee pains kept him trapped at home.
My knees hurt. Gradually, I noticed that the left knee was in worse shape. It swelled to twice the size of the right knee. It was tough for me to walk. I couldn't walk around freely. Climbing stairs was particularly painful. I had no quality of life to speak of.
For Wu Zhaoguang, Wang Hongying, and the youngster Gao Ronghong, medial abrasion syndrome severely disrupted their lives. Through his research and discovery, Dr. Liu has upended the mainstream view that knee OA is the result of degeneration or sports injury. In fact, regardless of age, anyone may be afflicted with medial abrasion syndrome because of injury to the plica or repeated knee bending.
If you notice knee pain or discomfort during motion, you may check yourself. Is the pain closer to the medial side of your knee? This symptom is very common. Because almost everyone has medial plica, if you repeatedly bend your knee or bend it suddenly, your medial plica may be impinged on and injured. The symptoms generally show on the medial side of the knee. It may be sore. At the end of a busy day, your knees may swell or hurt, or even get stuck. When you stand up from prolonged sitting, you may feel discomfort in the knees. You may not be able to walk without lightly shaking your legs first. These are all typical symptoms of the medial abrasion syndrome. Humans are born to walk and run. Our experiments have led us to know that cartilage in the knee is damaged only when the knee is bent more than 50 degrees. In walking, the knees bend less than 20 degrees. And in running, less than 30 degrees. Furthermore, the intermittent pressure during walking or running is beneficial to the metabolism of cartilage. We've learned that many patients feel discomfort when they repeatedly bend their knees, such as when they climb stairs, climb mountains, ride bicycles, or swim the breaststroke.
Dr. Liu's research also helps explain why females are more at risk of knee OA.
In the past, we knew that women and the elderly are more prone to knee OA, but we didn't know why. Now, we can easily explain that. First, old age means more prolonged bending. The numbers really add up after bending 1 million times a year, year after year. Second, females bend their knees more than males, so they get knee OA more than men do.
Mainstream medicine has not identified the etiological cause of knee OA, so they can only treat symptoms without treating the cause. Then they replace the knee. To help patients and medical care providers gain a more complete picture of knee OA, Dr. Liu established Knee Health Promotion Option, KHPO, to treat knee OA in 2007. The KHPO approach is distinct from mainstream treatment protocols.
KHPO is built on properly staging patients. During a patient's initial visit to our practice, we examine him or her extremely thoroughly, including X-rays and a physical exam. Then we assign the patient to one of 5 stages. The staging determines the course of treatment. Simply put, stage 5 is the most severe. There are no alternatives to consider because the knee is broken and the patient must have knee replacement. For stage 1 patients, symptoms only begin to emerge, so we basically do not recommend surgery. Stages 2, 3, and 4, and also stage 1 patients, must first get a knee health education. We teach them to debunk the myths they may have about knee OA. We show them our new concept that knee pains in older people are symptoms of medial abrasion syndrome, and that the degeneration of the knee is the result, not the cause of the syndrome.
There are 5 stages in the progression of knee OA.
In stage 1, the X-rays look completely normal, but patients show clinical symptoms, which are pain, stiffness, swelling, and stuckness. In stage 2, if we look through arthroscopy into the inside of the articular capsule, we can see some protrusions on the surface of the cartilage. The bumpy surface indicates that the cartilage has deteriorated and it contains more water. In stage 3, you can clearly see the narrowing of the articular capsule. Bone spurs have emerged. In an arthroscopy, the joint surface appears flaky and the cartilage has ruptured, and a whisker-like structure appears in the area. In stage 4, understandably, the cartilage is totally worn out and the joint space is totally gone. There are many bone spurs. In arthroscopy, you can see that the cartilage has completely disappeared. These light pinkish areas are bones. The bones are exposed. Clinically, you can see that the patient's legs have changed shape, typically becoming bow-legged. Stage 5 includes all of stage 4 findings, plus loosened ligaments. When he walks, his knee wobbles slightly with each step. No longer stable, every step is a struggle for him. This part is very narrow, severely narrowed. This is on the medial side, so your pain should be on this side too. In fact, you have some spurs here.
Dr. Liu put Wang Hongying at stage 3 knee OA, so the arthroscopic cartilage regeneration facilitating procedure, ACRFP, could still help her. While waiting for ACRFP surgery, patients are asked to do some exercises to prevent their condition from getting worse.
They will stay on this conservative treatment for 3 to 6 months. We show them why and ask them to do 3 simple exercises to protect their knees. If the conservative treatment works, the patient continues with these 3 exercises at home. They don't need any medications or injections. If the exercises do not help or symptoms worsen, then we'll recommend a key surgery that I've designed based on my understanding of medial abrasion phenomenon. It's called Arthroscopic Cartilage Regeneration Facilitating Procedure, or ACRFP. First, we remove the part of medial plica that is most severely inflamed. The articular capsule here has become very thick. This is where the medial plica has rubbed on the opposite cartilage for a long time. We must be very careful to slowly remove it. Don't hurt the surrounding healthy tissues. The ACRFP has 3 objectives. The first objective is to remove the culprits of knee OA, which are the inflamed medial plica that rubs on cartilage and the surrounding tissues that are inflamed. Both are removed completely. The second objective is to release the pressure in the articular capsule. Chronic inflammation in an osteoarthritic knee makes the articular capsule very tight. Cartilage can withstand intermittent pressure better than constant pressure. Intermittent pressure from walking, running, or jumping is acceptable to cartilage. On the other hand, constant pressure interferes with cartilage's metabolism. Like a sponge, cartilage relies on intermittent pressure for its metabolism. Press down tightly, then relax to get oxygen and nutrients into the cartilage. This metabolism is stymied if that pressure becomes constant, causing damage to the cartilage. The ACRFP releases this persistent pressure. The third objective of the ACRFP surgery is to remove all debris and locally inflamed tissues from the knee.
During the recovery period following an ACRFP, the patient should follow doctor's instructions and do the rehabilitation exercises, which we call postoperative cartilage regeneration facilitating modalities, or PCRFM.
Let's put the 3 simple rehab exercises into 2 categories. The first category is to strengthen the muscles around the knee. The second category is to improve range of motion. Our first exercise is to strengthen quadriceps, the muscles in the front of the thigh. Muscular strength there is critical. If muscles are strong, then the joint that they control is less prone to injury. Improved stability from stronger quads helps shield the cartilage from injury. The other 2 exercises, knee hug and press knee, are designed to improve the range of motion of the knee, which helps stretch out soft tissues. Inflamed medial plica thickens the articular capsule and raises the pressure inside, which is harmful to the cartilage. The knee hug and press knee exercises help loosen tissues and lower pressure. We urge all patients to do these exercises diligently.
I used to feel stiffness in my knee when I walked. It was especially stiff when I walked up inclines or stairs. My knees were completely stiff. When I woke up in the morning, the knees were stiff too.
But now, the stiffness and pains have disappeared completely. Wu Zhaoguang insisted on not getting knee replacement. Instead, he received the ACRFP, and he has recovered to enjoy his life again. After the surgery, improvement came slowly, but it had got better and better during the first year. When I returned for follow-up in the second year, my joint space had increased and cartilage had regrown. I'm most grateful to Dr. Liu. Now I can walk more smoothly with less pain. In November of this year, I had my follow-up visit 5 years after the surgery. Dr. Liu was delighted to see how well my knees had recovered. The ACRFP was very successful, and I was thrilled too. I treated 500 knees with ACRFP in a year, and we were able to follow up on 480 of them, or 90%, for more than 3 years. Overall, 89.4% of the patients were satisfied with the treatment. An important message for patients is that they should get the treatment early, like during stages 2 or 3. 95% of stage 2 patients were satisfied. For stage 3 patients, it was close to 90%. Most surgeons would recommend knee replacement for stage 4 patients, but we gave our patients arthroscopic surgery instead. 3 years after their ACRFP surgery, 80% of them were extremely satisfied with their natural knees. Mrs. Liu is 75. Following a friend's advice, she had her left knee replaced 9 years ago.
Both of my knees hurt. Ideally, both should have been replaced, but my age had precluded that, because that might have been too much for me. I got knee replacement on my left knee. It didn't work too well, so I didn't go back for the right knee. Mom's knees hurt because of osteoarthritis. They hurt so much that she could not sleep, bend down, or do many other things. Her knee replacement didn't help much. Same problems still bothered her. Her quality of life didn't improve.
Mrs. Liu's artificial left knee still hurt, and her natural right knee was also getting worse. Her complaint actually occurred after her knee replacement. Her artificial knee still hurt a little, especially on the medial side. There was discomfort and stiffness. It just didn't seem right. Her artificial knee was not functioning well. Our study of medial plica has led us to discover the cause of such pain and stiffness. Like all operations, knee replacement causes damage, leaving the medial plica even tighter and more fibrous. So we began to use arthroscopy to intervene. For patients who still experience discomfort after they had their knee replaced, we use our arthroscopic surgery to remove their medial plica and related culprits. And these patients are extremely satisfied with our treatment. As Dr. Liu suggested, Mrs. Liu received the ACRFP on her right knee, while her artificial left knee received arthroscopic medial release operation.
Now, 18 months later, she's able to walk in her neighborhood.
Mom had been in pain for many years. About 3 years ago, right? My sister told us about Dr. Lee. For a long time, Mom had been unable to stand for long periods or to squat, much less sitting on those stools. Now, after Dr. Lee's surgery, she can stand, and for a long time. She can bend and sit on those stools. She even does all the chores at home.
Now, Mrs. Liu often walks with her daughter in her neighborhood. To her, nothing beats being able to walk comfortably.
I often tell my students that we can be doctors only because patients need us. The insurance bureaucracy and the medical care industry have introduced many obstacles that distract us from doctoring. When we're frustrated by those, we only need to look to our patients for strength. Their satisfaction, positive feedback, smiles and joy are what have propelled us at Tsuji, what have propelled us to keep going.
A new pathological finding has led to a novel arthroscopic surgical procedure which Dr. Liu's team uses to provide an effective alternative to knee replacement. People long suffering from knee OA now have good reason to hope that they may keep their knees.